Rare Disease Day shines a light on conditions that are uncommon but life-altering. Biliary atresia is one of them, affecting about 1 in 10 to 20,000 infants. Because babies may not appear critically ill at first, diagnosis can be delayed, and time is critical. Early intervention with a Kasai procedure can preserve the native liver, while delays often mean earlier transplant and lifelong immunosuppression. We're spotlighting biliary atresia to emphasize the importance of early recognition, coordinated care, and the voices of those living and working on the front lines of this rare disease.
Biliary atresia is a cholestatic liver disease that presents as l- collapsed bile ducts or missing or atresic bile ducts. So the bile ducts aren't active or aren't working. And so what ends up happening is instead of the liver secreting bile and all its chemicals through the bile ducts, it has nowhere to go. And so the liver becomes cirrhotic, producing all this bile and all these chemicals. And so the way it presents is that the indirect bilirubin is broken down by the liver to direct bilirubin, and then this keeps growing and growing and growing, and then the kids become jaundice. And so uh, once you see this jaundice, you have to test for fractionated bilirubin. And the reason I say that is the most common causes of jaundice are physiologic: breastfeeding, breast milk, just natural jaundice. And the majority of babies are jaundice. More than 60% of babies are jaundice. And so you most of the time it is not biliary atresia. But if it is biliary atresia and we're saying, oh, this is normal jaundice, it's physiological, we're not fractionating and we're missing the direct bilirubin, then the kid's gonna get worse. And the reason the kid's gonna get worse is by the time we say, okay, this is not physiological, find its biliary atresia, and let's say we're 2, 3 months out and we want to do the Kazai. The Kazai is just in medical terms is the hepatoportoenterostomy, which means you're connecting the intestines directly to the liver, and you're praying the liver just dumps everything down through the intestines, and it works. But sometimes it doesn't, and as more time passes, the less likelihood of the Kazai working. I was once told every day in delay after 60 days is like an increase of mortality by 2% almost. And so if we're just saying, oh, it's jaundice, it's physiological, and we're not testing, and then your kid is the one in 15,000 that is the biliary atresia, you're not giving them a shot to survive and to do well. And if the Kazai doesn't work, then all your options are left are transplant. And so at the end of the day, biliary atresia is rare, but it is one of the causes of jaundice that we should keep looking out for because it is a dangerous disease and can be managed easily if caught on early.
Those infants usually they don't look sick during the first couple of months, and breast milk jaundice is a common thing. Sometimes patient can be jaundice, but they don't have liver disease. So basically, this can be dismissed. This like yellow discoloration of the eye or the skin, that it's just a benign process that most newborn gonna kind of outgrow. But there is this subset of patients who have the direct bilirubin elevated or the conjugated bilirubin elevated, and you would not make this diagnosis unless you fractionate the bilirubin. Those patients, if missed beyond like the first like 60 days of life, the outcome going to be really dismal because the opportunity to intervene with the Kasai, which is really a palliative surgery, but it can, there are some baby who have this surgery can live with their native liver up to early adulthood. So it's an opportunity to give them maybe a childhood free of immunosuppression, because in liver transplantation is still the radical therapy, but liver transplantation come with its own kind of um, and you're trading one condition for the other, basically. Patients with liver transplant are on lifelong immunosuppression for now. There are some risks associated with the surgery per se. So we make these decisions like, to proceed with a transplant in a patient who have failed the Kasai, or a patient who have like not underwent the Kasai in a timely manner. This is a rigorous kind of process to make a decision to transplant someone and list them. And for them to get a liver, also sometimes the wait on the waiting list is long. So the effort right now is try to make a diagnosis in a timely manner, and then to proceed with the Kasai.
Biliary atresia is rare and often difficult to recognize early, and when diagnosis is delayed, the consequences can be profound. For families like Ashley and Taylor Rhodes, It unfolds not in textbooks, but in hospital rooms, where, within weeks of welcoming a newborn, they were asked to make life altering decisions and step into the unexpected role of caregiver.
We had an appointment at his pediatrician. It's something that I said, hey, we're going to go in after a few people had mentioned, John looks a little yellow. And as a mom who had two kids previously and they had jaundice, I wasn't super concerned. And then his belly looked a little off, but John had a diagnosis before his BA diagnosis. And so he was constantly eating every, like 30 to 45 minutes because he was so hungry. So I was like, oh, it's because of this diagnosis. But we went to the pediatrician and she said, hey, let's do some testing. And I said, okay. And she's like, when we get those back, we'll call you if anything seems wrong. And I said, okay. And then we got the call and she said, is Taylor sitting down? Are you sitting down? And I said, no, but we can. And we had just had friends come in from Colorado to visit us. And she said, so I'm going to need you to pack some bags and go to OU Children's Hospital. And you'll be greeted with a team of doctors. And I think at that moment, my heart dropped and just started crying and started thinking the worst. We got there, a lot of doctors. We had to leave our two kids. And then we were in the hospital those 2 days. And I think that's when I kind of just zoned out and was like, this is now your responsibility, kind of. You're in the medical field, and I have no idea what they're going to be talking about. So I'm going to care for my baby, and you're going to take care of everything else.
You're shifting this mentality of being a parent to a caregiver for your own child, and it was really overwhelming because you it's sort of like, as she stated, just really overwhelming. You're trying now to understand, how do I even discipline someone who is right at a certain age, but is going through this. And so it's a struggle. It's a balance though also, and it has to be a well-maintained balance because you don't want to give in, because having three other kids and showing favoritism, but also having them understand that we are John's caregivers. We have to allow certain things and not allow certain things, and that is tough. That's very difficult, because you no longer are acting in that parental mode, but you're acting in this mode of, this is what's best for John, not because of, again, maybe some type of parental reason or excuse, but it's because it's for his health. And that takes it to a whole nother level of, and it can be very, very much emotional, overwhelming, um, and the decision making as a caregiver is so much different than as a parent, I think, in my opinion, because you're making these decisions about whether or not, like the doctor asking, like, hey, we want to do a Kasai for him. We'll need obviously your permission. No idea what that was. And now I'm having to make a decision whether or not my son, lives, and whether or not that's the appropriate course for him.
It was a decision that had to be made right away. Like, it wasn't like, oh, let me think on this for a few hours. It's like, no, we need an answer right now. Or are we moving forward?
For parents, the decision to move forward with a Kasai is urgent and deeply personal, shaping not only a child's medical course, but a family's entire perspective. For Amada Nuti, that experience began in infancy and ultimately inspired a career dedicated to improving care.
I had my Kazai at 77 days, which is way over the benchmark of 60 days that most centers aspire to. I had my transplant because of hepatopulmonary syndrome that took a year and a half to diagnose, and I was satting in the 70s oxygen. Post-transplant, I developed post-transplant lymphoproliferative disorder, and for those who don't know, this is a form of non-Hodgkin's B-cell lymphoma. And so with all that happened, I was like, yeah, I think there should be better ways to manage a disease. I know I'm rare, but like at least I think I should be put through the ringer, and I don't want others to go through the ringer like me. And so that was the inspiration of me doing medicine. And then while doing my career in medicine, found research and I fell in love with it because I realized that while my clinical work directly impacts 1, 2, 10, 100 patients, the research I put out, especially if it's quality, and this is what I hope to do, impacts a broader audience's life. And maybe one day we can help improve the guidelines and the management of biliary atresia in a way that kids don't have to suffer as much as they currently do. So this, my disease has framed my whole output on life and on my goal to help others like me.
So I think what I've learned from biliary atresia, again, not specifically the disease, is that there's diseases out there that could just affect anyone that does not have anything to do with genetics, that doesn't have anything just to do with, and so have empathy for that, right? And a more general awareness for someone's story and for someone who's going through something that's very similar, like biliary atresia. And I think that awareness does allow you to just, again, not be fearful, but just be ready for something that could unexpectedly happen, in someone's life. And so and again, when that does happen, have empathy for that individual.
Yeah, no, I agree. I also think that for me, I mean, it was a disease I never heard of. And so what do? You go to Google, right? And you start to research, and all I saw was like, well, this is what happens if you don't take care of it right away. Um and so here I am thinking, well, we're 20 days, we're 28 days. And by the time he got his Kasai, I think we were like 32 days. And I was like, oh my gosh, we're reaching that point where like we don't know what's going to happen. But now, as I research more about VA and I talk to a bunch of people about it, like we had time then and we moved fast.
Yeah,
And I think that's where I say we were lucky. We move so fast, and not everybody is that lucky. I've known people who've been diagnosed
yeah.
like at 3 months old, and it's just like, wow.
When we hear the word rare, we often think alone. I often equate that as to being alone, right? But that doesn't mean that you're alone.
Mhm.
There are a group of people out there who have walked the same path, very similar to yours, and that can help you get through that. And so I think most people just as hear the word, your son has been diagnosed with a 1 in 20,000, rare disease. Like you just think, oh my gosh, like what am I going to do? Who am I going to turn to? Who's going to understand me? But as Ashley said, there are support groups out there. And then even at that, there are many advocacy and organizations that help you understand the plain language of what maybe doctors are telling you. Because also working in healthcare, I know we tend to, the way we communicate is not great all the time. We sometimes over communicate. We sometimes are very too technical because um, we want to ensure that we're giving all the information to the patient, but there are advocacy groups, there are support groups who can put that in plain English, plain language for you to understand, and that can also, like I said, as you stated, can help you walk through that path.
Also, I think where I got where I started to get comfortable with the doctors is when I was like, hey, I don't understand anything that you're saying medically. So just break it down for me. Like speak English to me, basically. And they did that. And that's what they want. I mean, I sit on a board at our children's hospital, and so we always find new ways to help parents. And one of them has been making sure that the doctor is sitting down in the room with you and not standing, because then it feels like you're rushed and you don't have all those questions. And making sure that you just tell them like, I don't understand what you're saying, but if we can just talk, or you run your rounds and come back, that'll help me instead of feeling like we're rushed.
Yeah, I remember our doctor drew it out for us. I mean, he literally put it on the board and made a drawing, and I was just
He's like,
like,
this is
and
John.
I was
This
like,
is
this is great. Like every doctor needs a whiteboard in their office, so that way we can just draw it out because it makes sense. I know again, we tend to um categorize a diagnosis, and we tend to um put them all within one bucket. Every biliary atresia patient is like another, or every cancer diagnosis is like another. I would say, right, um, everyone comes with uh, their own backpack that they're carrying with them prior to a diagnosis. Um, sorry. Um, and so I think the best thing I've learned, especially being in healthcare, is that understanding where people are um, in their walk of life as it relates to an additional diagnosis um, can lend itself for a provider to be more empathetic, um, learn how to communicate differently with every different parent, every different patient. And so I think my advice would be that don't assume that your next patient's going to be like your last, especially the parents, especially, um, and so I think that will help with the caregiver experience overall. I mean, and with the patient experience, and so I think it really does lend to just understanding where they're at in their walk of life, and sort of modifying how you care for each patient.
I think that we all just come, everybody has BA, but we all have a very different journey. I mean, there are kids that I know that have something different from John. And I think also the hard part for me was when John had two diagnoses, they were like, let's double check this because there's no way he can have these two diagnoses. And we did a lot of that, but also communicating with each other and being on the same page is helpful for parents because we're not having to go from, oh, well, this doctor said this and you said this, and then his genetics said this, and infectious disease said this, but you said this. That's really hard for parents because it feels like we're being bounced around and different things are being said to us. So if we just all get on the same page, that makes it easier for parents too. And then let's just have a one big meeting. I mean, that's what they do for John. If there's something that we can't all agree on, then they're gonna have a meeting, and then we're gonna bring mom and dad into this, and we're gonna decide what works and what's gonna work for John. And always, just always make sure that you put the patient first. Like I know that they say that, but think about the patient, think about the family, and think about the siblings.
Stories like these underscore the urgency around biliary atresia and the need for progress. Advances in biomarkers, imaging, genetic testing, and screening are helping clinicians diagnose sooner and manage the disease more precisely, offering real hope for better outcomes in the future.
Non-invasive biomarkers. Some of these, like as we said, the blood-based MMP7, there are lots of data on it. Now it's commercially available. It's interpreted as part of the, diagnostic workup. A standalone, it would not be very helpful, but if you integrate it in your workflow and see like how it fits your kind of diagnostic kind of criteria, it does help. And also there are more work done on this duct at the hilum. It's more ultrasound based tool to try to make a more of an accurate diagnosis of biliary atresia, because the regular ultrasound we use, it's helpful, but it doesn't rule out completely the diagnosis. And sometimes it's kind of a patients still have kind of evolving of these pathological features over time during the newborn period. So, and we all have those patients when we have biopsied first and it was not clear-cut diagnosis of biliary atresia, but the patient did not improve and they end up with, an intraoperative cholangiogram later, and it was indeed biliary atresia. So the diagnosis of biliary atresia, even with the biopsy, although there are specific kind of histological feature, sometimes these are not kind of fully manifested on the small liver biopsy that you can take from the whole liver, and you have this faith that it's going to be reflective of the pathology. So this is something to take into consideration, that the biopsy is still the gold standard, but the biopsy alone might not be very informative if it's taken very early in the process of the disease. Also, there's always what we call sampling error with the biopsy. So it's very important to follow through and make sure that this patient did not continue to worsen, and some patient would need another biopsy or another intraoperative cholangiogram to make the confirmatory diagnosis. The other thing that happened over the last decade is these cholestasis panel. So those are kind of commercially available. They have a short turnaround time. And if you have a clear-cut genetic diagnosis, then that confirm the clinical picture, then the diagnosis of biliary atresia is less likely, and you don't have to put the patient through the invasive procedure of a liver biopsy and the intraoperative cholangiogram. So this have changed the way we manage patients, because now we can see them early. If they are referred early, we can send this cholestasis panel, and sometimes we can arrive to a molecular definitive diagnosis, which can save the patient more invasive workup. So these are the main things that have happened. In addition, like some country implement the stool card, where they kind of look at the stool color and try to just report when there is concern about this clay colored stool, or to make an early diagnosis. This is not implemented widely in the U.S. We educate family, but if you have a normal newborn baby, like I don't think the pediatrician have to do this anticipatory guidance about this particular issue. So it's kind of not high on the list of priority that general practitioner discuss with healthy, otherwise newborns. So maybe there's more that can be done in this field, just to try to educate more about like the stool card and the stool color. And then there was an initiative to incorporate the bilirubin, the direct bilirubin even, into the newborn screen, because a direct bilirubin more than one, need to be followed. You might not need to act on it immediately, but you need to follow it longitudinally to make sure it normalized. Because the patient who never normalized their direct bilirubin, for example, checked as at day 1 or 2, like rechecked at 2 weeks, those patients, if they have upward trend or never normalized, those going to need to be really worked up. So this is another way to kind of diagnose this condition early. Those are kind of the major things that have happened over the last 10 years in the field that, have helped streamline the management or the diagnosis, hopefully, of biliary atresia, but there is more to be done, basically. The other thing that, like, the newly approved IBAT, those ileal bile acid transport blocker, those have been very helpful in the genetic cause of cholestasis, but there is a subset of patients who would benefit from them. There is clinical trial ongoing. It's not approved for biliary atresia, especially if they have elevated bile acid after Kasai and they have a lot of itching. And then the thought is, like, elevated bile acid has been also linked to outcome. So like a bile acid level over 100 has been associated with that, with kind of undesired outcome. So this therapy may prove to be helpful in the future to prolong the life of this native liver, but at least they can provide symptomatic relief from itching, which is kind of a debilitated symptom in patients who have like normal bilirubin. They're not jaundiced, they have normal liver function, but they're still having a lot of itching. And hopefully with time we'll see if like lowering the bile acid doesn't only improve symptoms, does it also reduce liver fibrosis and progression to end-stage liver disease. So more to come, because those are newly approved therapy in genetic cause of cholestasis, and they might have role in biliary atresia. We will know maybe in the next few years.
Yeah, I would like to start in a positive sentence. I think whenever clinicians, especially non-hepatologists, and families hear the term biliary atresia, they look at it as if it's a death sentence. But I would counter argue that no, it's a complex disease that is perfectly manageable at this time in life. And I think what I would like them to know are a couple of things. First of all, your kid is not limited. He is medically ill, but he is not challenged, or he is, the limitations are what you set your kid forth. So if you are not giving your kid an opportunity to learn and develop with the disease and understand themselves, that you will limit them. However, I've seen remarkable biliary atresia patients. I'm not the only biliary atresia physician. I've met a couple others, and so sky is the limit. That's one. Two, proper management, be an advocate, whether you're the patient's a pediatrician or the family member, be an advocate. When you feel something's wrong, I can't count how many times my mom caught on things before physicians could. And so I would say be your kid's advocate. And finally, post transplant, you go from a life threatening disease to a chronic disease, you're on immunosuppression. Uh, I think, and this is easier said than done, with time, you have to accept the fact that this is not a limitation, but this is your thing in life. And it makes you better as a person because you value life. And just, I live my life with biliary atresia, with a transplant, and on immunosuppressants. And I think it's the best thing to ever happen to me because it gave me purpose and gave me a perspective on life people live all their lives to get to, and sometimes don't even get to. And so I'm grateful for the disease because it made me who I am today, and I wouldn't change a thing about it.
Biliary atresia is rare but life-changing for families. Early diagnosis, better tools, and continued innovation can improve outcomes. On Rare Disease Day, we recognize the urgency and the people behind the diagnosis, because rare should never mean invisible.